Alright, thank you for joining us.
Alright, we are live.
Alright, thanks for joining us for our third Facebook live stream journal club. And we will post this, I guess there's two things posted now, and we'll shortly post this one after today. Not much new is happening, right? Why don't we just go right into interesting calls? Who was primary this week?
Josh, and I believe he's finishing up his call right now.
Josh was late. 1:19 and Josh is not here.
It must be an interesting call.
Hopefully when he watches this video, because he missed the first few minutes, he'll pay attention to important dates where we need no answers about things today. And here he is.
There he is. Do you have an interesting case? Starting interesting case. I don't know what happened.
So, Josh, we went over important dates that we need answers to today. So, pay attention to Melvin's email. We need to know there's several dates we need to review things.
Well, we can talk about his trip. He just came back on a flight.
All right. You just, without, talk about
And identifying features and stuff.
In all fairness, Josh's been working hard. He probably didn't sleep last night, but he can sleep in fellowship. So, you want to talk about, just give people an idea what the trip was yesterday?
Yeah, so to take 2 of 24-month pregnant kids from one state to another via airplane. Their delivery was complicated by intrathecal hemorrhages, lung disease as well, and vision problems. So they say transport to get them closer to home, so you're not going to view. They were in another hospital for the last 5 months, where they've been gaining weight and doing better over time, and the Charter family was very far away from their home state, and it was kind of in split for the past 9 months. So we were able to bring them home. The flight went pretty well. Both kids did great. We had everything.
So this kid decided that hemorrhages had like the BPD, right? Chronic dysplasia, which is common in some of these. In 24 weeks, he's very young to deliver. Probably like 60-40 chance of survival, maybe a little bit better nowadays. When I was a resident, it was 50-50 at 24 weeks. And so these kids, the goal is like to leave them alone and not to stimulate them, because if you stimulate them, they get bradycardia and happen, and that happens a lot. So we were worried, or at least I was worried, that doing up in the air will cause pressure on the eardrum and stimulate them constantly and become more active with bradycardia. So that did happen, right?
There was one episode of the stats drop, other than that, nothing else. Yeah, they actually did pretty well. They were working around for the first time on the airplane. They're all going to want to fly private now. They're going to be spoiled. But yeah, they were just looking all over the place to see what was going on.
And you left these kids stats to be like in the mid-80s, right?
Yeah, so one of them was actually did well. He was on 1 liter, and he was doing fine the whole time. And then the other one was on 3 liters, and his stats dropped. So it was in between mid-80s and mid-80s and high 90s.
The mid-80s for these preemies, totally okay.
Yeah, we had an neonatologist who comes flight with us who said that he doesn't get blood unless the patient starts becoming bradycardic. And then the nurse who was on the flight with us also said that they routinely not get white until the stats are consistent in the low 70s or so. So for these kids with their lung disease, so yeah, we're really sad.
So we took a whole team. We took one EMS physician, which was Josh. We also took a NICU nurse, we took a neonatologist, we took a paramedic, and then we took somebody who did some logistics for us. And we got into the hospital with us. And I actually did with them. So I think we're okay. And then you had a tactical job. Anything else about them? I mean, they had large friendship with them.
Yeah, grade 4, both of them. I didn't see that going. It was ready from the report.
And really, when they start scrap, you really just bag them up. Not much they can do, right?
Right.
You just bag them up, and most do better with them.
Right. I mean, we make sure that they hadn't had any VSATs previously, and that they were on the car seat. And or left her something that wanted to get to 4 hours in the car seat, and VSAT
is courtesy of Matt Harris, right? So it's
Well, they do it in most NICUs, PICUs,
Right.
place them in a car seat in the hospital just to see if they tolerate that position.
sort of a car seat testing, and you basically just see if they can use that during the car seat and enable them to the car seat. They both pass the car seat test.
Yeah, I guess it's something that's definitely important to think about. But it's not something that we, like, as emergency doctors, always see kids getting discharged from the NICU that wouldn't be even thinking of them in the car seat before we just get them in the car seat and we'll into the hospital. But I guess it's definitely something that's important to think about before transfer.
And then number 2 years this is a car seat instructor course. It was rough. It was a week long, and basically the car seats to get the car seats in. But then you also learn about the types of cars and what cars have car seats, or what cars you put the car seat in certain ways and what cars you put in different ways. It's a very long, very long.
You get to sit in a car seat?
I didn't. Any other interesting
I have to look how that just came from. I don't know what the results are yet, but I was right in front of the store on the way to dinner club, so it was, I had to stop by. It was basically when someone, a lady probably in the 60s or so, when collapsed, said her chest was hurting her a little bit before, and then she passed out. It's just also that she was conscious and ambulatory with her in the back ambulance. She sat in the high 80s, the low 90s. We have a bunch of PVCs on the really bubbly on her, showing just sinus attack at a rate of about 110 to 280 versions of 180 L. And the QRS was borderline on the wide side. It started to probably look like at least the start of a right bundle branch block. And she was hypoxic as well, in 85 to 81. So I don't know if this is more than possibly had a TB. It didn't seem like it was systemic based on the behavior, and she also wasn't complaining any of this. So it's down the stairs now. Let's see what happens afterwards.
I'm sorry, did you get time to echo her?
I didn't echo her. I used on here, so I don't know if they'll.
Right, so it's just, we can see on the echo that there's an RV strain, but obviously she's probably she can't get a deep down the risk, but she's too high risk, so she's not the right person to get it. What are the S1P3 features? Is that made up? I mean, what percent of people actually have that? We all learn about that. You have an S1P3 and COVID-3G.
Whenever I see it on timer and it's negative, so I stop.
So whenever you see it, you're getting a CPU, you're getting a CT angio, then it was
Well, no, I'm not going to get CT angio. I'll just, I'll consider that a risk factor, maybe a point on the low score in my own head, but it's
right. You have to say, look at the test question.
in real life when you actually see it. I feel like it's just not.
So it's an S1 Q3 T3, right? And I don't know. I stopped looking for it, or I stopped paying attention to it. Somebody had it and it didn't make sense to get into PEIs more, and if they have it, or they didn't have it, still would get it as a appropriate position.
Yeah, and most of these clinical scores are just people who don't have that clinical result.
But it does make a good test question. That's one piece of that's how you do it.
I think in reality, you see T with emergence and interoceptively as well. Right on the blank blocks, they're all sounds as well. Person that is being regular science, but I don't have science tag.
Other interesting calls or CRTs?
So Justin and I don't think we talked about this yet, that cardiac arrest that we had. Yeah, that's right. The one we showed up to the house, it was like a guy in his 60s, he, unknown downtime, the wife came home and found him in his bed, kind of face down, and then he was found to be pulseless, they were unsure if he had overdosed, not he had a bottle of opioids next to him. Yeah, he had a bottle of opioids next to him, and they were unsure if he overdosed or he just finished his prescription because his prescription was lethal. So it was very unclear, and we basically arrived on scene, and they were in, I think, the second round of CPR. And it was at that point, it was a narrow complex PEA in probably it was rated cardiac, so it was maybe in 30s to 40s, I think. So we had our ultrasound there. So, we put it on, and initially the first pulse check when we checked, I was surprised to find that there was actually not any contractility in the heart, even though it was complex broken mechanism and pretty cardiac, but it was just a little valve restriction. So I anticipated that would be in like the 40s, 30s, 40s. So I anticipated that we just got to him a little too late, but I think we ended up doing, Narcan, we were running ACLS protocol. He went into deep fit once while we were looking at the heart, I think, because all of a sudden the heart just had an always very certain. We were like, what is that? Up to the monitor, and it was a tiny fit. We were shocked him once, and then he went back and integrated kind of PK rhythm, where there was no contractility on the ultrasound. So,
Okay, so hold on 1 second. So, this is like a litmus paper, right? You want to read one paper about PDA. The little paper is not really anymore. All you had to do is read a litmus paper. I mean, Josh, yeah, we have to like Josh presents at the NAB. So if somebody says to me the patient's in PDA, that is a meaningless term. You have to tell me what you see on the monitor, because how I treat PDA with a Y complex is totally different from how I treat PDA with a narrow complex. So you gotta tell me. So never say anymore. Everybody out there, never say anymore that patients with PDA without following up by saying what is on the monitor. So Josh, if you just present the litmus, if you want to elaborate on that.
Yeah, so an 11 paper basically talks about different PDA dividing into two categories and why they're non-complex. Based on that, it will help us differentiate our treatment and our management and what we should think of basically what's going on with the patient. So in the setting of a narrow complex PDA, we're going to think about inflow or outflow problems from the right ventricle. So those are going to be your PEs, cardiac tamponade, tension pneumothorax, and anything going on with the vent, basically. So if there's increased pressure from the vent, that can cause decreased inflow to the RP. So in those cases, we're going to want to treat the cause, but how can we differentiate what's going on in between those four, and then we have our ultrasound to do that. So by looking at the ultrasound, we can see if there's a dilated right ventricle, right atria, which would indicate PE. If we see fluid around the heart with collapsing of the ventricle, especially the right ventricle, and then we can tamponade and we see pericardicentesis, and then if we can look in the lungs here and look for lung sliding and mode for that same beach sign. And if it's not there, so the way what it looks like is it kind of looks like a beach with sand and then waves, and that's gonna it's on the end mode with the ultrasound, as opposed to what kind of looks like a barcode, which is just going to be a lot of straight lines going across that are kind of equal. And the reason why we see that is because of the parietal and visceral pleural layers rubbing against each other, which should be going in the normal case, but when there's air in between them, then they're not going to be rubbing against each other. So that's how we can see on the ultrasound. And if we do see a pneumothorax, especially tension pneumothorax, it's something we absolutely need to discuss in the field. And then if you're bagging a patient, or if the patient's on a ventilator, then you may be bagging too much, or the ventilator settings may be too high. So you need to kind of think about what's going on with that and possibly allow them to exhale more time to decrease the pressure that's going on in the chest. And then for the Y complex QRS, that's going to be something metabolic or ischemic going on. So hyperkalemia is definitely something that's important to think about, and the treatment for that, especially. And this is a lot of good knowing by your history as well. So if they're hyperkalemic and sick renal disease, you're going to want to give calcium. If it's a suicide attempt or overdose of medications, and you see a Y complex, you're going to want to think sodium channel blockers. Yeah, absolutely. Yeah, anyone bradycardia, yeah, and hyperkalemia can really cause anything. EKGs, yeah.
in the hospital,
Right.
it crosses your mind. It's counseling. Like, if you're wrong, if you're married, and you're right, it's like,
Exactly.
and it's very simple. They have a result is 1,000 milligrams of calcium chloride. Calcium chloride 10%. 10% is, brought down to percent at 0 milligrams per ml. So 10% calcium chloride is 100 milligrams per ml. Do 10 ml, just drink 10 ml. And you take fast, it doesn't matter. And you can get better.
And right, and for the TCA or sodium channel block, TCA, you want to use sodium bicarb for that as a treatment. And then if they're ischemic and you're showing stem-in EKG, no pre-hospital, you're giving an aspirin, any additional interventions that need, plus or minus oxygen depending on what's going on, and possibly pain medications and nitro, and whatever. It's a whole other discussion with all that stuff. And then the other thing to think about if you see a wide complex QRS is that it could be any of the reasons that are going on with narrow complex if they have a previous conduction delay. So if they have an old right bundle branch block, an old left bundle branch block, they're going to at baseline have a wide QRS complex. So, and that would need to know whether you're seeing an old EKG or if someone will tell you. And so it's kind of a way to think about EDA and why the narrow complex and how to. And they felt in the paper that it was easier to remember, and I agree that it's easier to remember than all the H's and T's that are going on. And also, if we remember the H's and T's, if we can even list all 10 or 11 or however many of them there are, we have to remember them all and then remember how to treat them and how do we determine which is the most likely one going on in this case. So I think this algorithm kind of helps divide it.
Now it's wider and narrow, like you said, wide. Think about everything, and narrow, think about that, if they were in the ICU and they're in narrow complex today, maybe they're less than 40, and they would have a blue line, and we would know they're less than 40. But if they're pre-hospital, you don't know this, so we start CPR, which we know is a death sentence for most people. So as an alternative to not do compressions and actually just get the good pressure, get the blood pressure up higher, and then maybe, they will have a better outcome. And of course, at the same time, like this is.
But this guy ultimately, another thing to throw into the mix, his end title was consistently 30s to 40s, right? Very high.
with no cardiac activity.
With no cardiac activity. So we worked it for a while.
Right.
We went.
Which
I
means
talked to
one
the
thing,
family.
they were doing good CPR.
Right, they were doing great compression. I think at one point we gave bicarb and it went up a little bit more. I don't know if that's right or not, but
Even though we just reviewed that study about not doing bicarb and cardiac arrest.
Yeah.
So, and were they subjectively doing good CPR?
They were doing great, and Dustin got on the chest as well. It was great CPR, but at every pulse check we looked at the heart, and there was no squeeze. The valves were twitching a little bit, and I was ultimately random calling it, and it was really hard to call it because I think the ultrasound trumps the end tidal CO2.
But in the old days, we would have just called this,
Yeah.
and we wouldn't have known anything. Now, at least we feel bad because we're calling somebody who were like at the one step before Ross, and we just don't know how to get to that last step in medicine. And that's the problem. And
The paramedics were like, what is end tidal 30? And I'm just like, look, I'm looking at this heart, and it's not squeezing at all.
right. This is the struggle we have. Because we know that if your end tidal CO2 is less than 10 every 20 minutes in resuscitation, there's 4 studies that say you have 0 chance of survival. This guy is how to do all good CPR. Because you should measure your CPR not based upon what it looks like. You should measure your CPR based upon what your end tidal CO2 is. Because we know that the proper compression depth is, right, particular circulation is actually 1.7, not like 2.5. Like those numbers aren't right. 1.7 is the best outcome.
Too high, too low, and it's not
Right.
the same.
So we're at the one step before. Maybe who knows why you couldn't get better contractility. But maybe that person really had no chance of survival. Maybe it was just these guys came along and did really good CPR, and that's what generates.
And I kept thinking, maybe he was just, extremely hypercapnic, where, maybe it was respiratory acidosis, for example. He did overdose on the opiates, and he was sitting there for a while on his bed with the face down, so his CO2 went up into the hundreds.
Yeah, it's a brilliant comment. Or maybe he lived up in the 80s. And people actually live with PCTs 80 or 100, right? But maybe, but the only problem I have with that thought is that they get there and they're ventilating him, and then the NCAL CO2 is probably going to go down no matter where he lives, no matter how he started, just based upon the compression or bigger than the ventilation. Right. So yeah, this is the problem we're having now that we're getting better and better. We're just one step away. But he wouldn't have been like an excellent candidate anyway, right? Because he had no flexibility, no matter what the monitor said.
Yeah, nothing on downtime.
Right.
Yeah, his downtime was probably too long. That's probably what did it, Jim. If he had a shorter downtime, maybe it would have been different. Do you know how long his downtime was?
No.
The wife came home and found him like that, face down. And I don't think that she started CPR either.
No, I don't
The
think so.
BLS arrived and started. So.
Was he young?
He was actually, it's like 50s,
Oh,
like 50s, I think.
50s.
Yeah.
So it's quite possible he had he had a good heart too. So it was easier to get that. And how's the function of left ventricular squeeze?
Yeah.
So his left ventricular squeeze was good for doing CPR, or at least something was good because left ventricular CPR.
No real past medical history.
And from all those other papers that we were reading about, best case scenario for cardiac arrest, witness arrest, entitled greater than 12, was it, or 10? Immediate CPR, good CPR. I had a case a couple of weeks ago on a control where they had a young guy, 30 years old, recent gallbladder surgery, was found down by his family, and they called me after 5 rounds of epi. Entitled was 4. I confirmed that it was 4, not 40. So I told them, if you want to, try some bicarbonate and some calcium, sure we can do that. But if nothing changes, let's go ahead and because of medical futility, we'll call it.
Yeah. Any other big cases of ER or in hospital?
I had a similar cardiac arrest 2 days ago down by the shore. Middle-aged guy, I think he was very young, 50s.
Why don't we catch them in the 50s?
I don't know. This guy he pulled up to the supermarket, got out of his car, and somebody saw him kind of like reach for the sky, and then he went agonal and collapsed, and that was it. So he had all of his prognostic indicators as witnessed. People ran over, identified immediately, he didn't have a pulse, called 911. They started compressions, BLS arrived, took over. I think once they got the AED hooked up, 1 shock was advised, and ALS arrived, and they, IO'd, they drilled him, gave him some epi, and, ultimately I think they got lost once. By the time I showed up, they lost pulses again. So I don't know if it was like the intubation or what, they probably made pulses again, you never know. But he...
Because they didn't do CPR during intubation.
I don't know.
Did they give assist us?
I don't believe so. It was a complicated case. Ultimately, though, this guy had all of his prognostic indicators. We worked him for like 25, 30 minutes in back of the ambulance, but we just could not bring him back. The ultrasound, same exact thing. Cardiac activity just slowed down to a standstill. And this was actually one, while we were doing compressions, I could put the ultrasound on, and I said, hey, this guy has a big heart, and I actually moved it over so we could see his left ventricle compressing. So it's like we were doing everything right.
So did you move where your hands were for CPR?
Yes.
You
Based
did.
on the ultrasound.
That's great.
Because we could
great.
we could
This is
we
what
did-
the science says. Like stop doing compression with your ultrasound where the BMI is, not necessarily over the shoulder.
That's what medics are always impressed when you show up on the scene. You're like, actually, just move a little bit to the left because it starts to, a little deviate. They're like,
Well,
oh, really?
Yeah, that's from all the ultrasound papers
So-
that we've gone over and all the mechanical CPR devices as well.
So when you moved, did you get better end-tidal CO2?
I don't think so, actually. He was already below 10 at that point.
That was below 10.
Yeah, so he deteriorated, he deteriorated very quickly, and I just, we ran him for like 25, 30 minutes and ultimately did a PRE. I was looking at his lungs to make sure I wasn't missing pneumo or, something like that. But every once in a while, despite having all those big prognostic indicators.
I think he was on heat, was drowned.
No, he was just pulled up to the supermarket and
Which ultrasound machine do you use?
the new one. That was
Alright, any other cases? Alright, we want to do the articles. Just want to do the white dress from 2 weeks ago. So it's not letting. I mean, it is kind of an EMS thing because we have white complex people having tachycardias all the time. And I think I always tell people that there's only one rhythm in medicine that concerns me. That's a wide irregular rhythm. Nothing else bothers me. You typically know what to do. React know what to do. SBT, rapid AFib know what to do. So if it's a rapid rhythm, I say is it wide. If it's a wide rhythm, I say is it rapid. So a wide, I'm sorry, I'm saying this wrong. A wide irregular rhythm. So a wide irregular rhythm bothers me. So if it's irregular, I say is it wide. If it's wide, I say is it irregular. So everything else you know what to do. But wide irregular rhythm are the things where we can actually harm patients if we're not smart about it. So all yours.
Okay, so yeah, this paper, the differential diagnosis of wide complex tachycardia, more so talks about coming to terms with differentiating between the wide and complex tachycardias. So wide complex can either be from a supraventricular rhythm or from a ventricular disturbance. So when you talk about from a ventricular disturbance, things can be monophagic VTAC or polymorphic VTAC. But when you start talking to them from a supraventricular tachycardic standpoint, you start thinking about aberrant rhythms. And this opens up the door to numerous differential diagnoses. So you can have SVT with aberrancy, AFib or flutter, ventricular nodal reentrant tachycardia, and then the pre-excitations. So, mentioning this paper is the Wolf Parkinson White with AFib and then with AV reentrant tachycardia. Sorry. So it goes over some key characteristics of each of these wide complex tachycardias, certain things to look for, and if you want, I can talk about specifically point out each one. Okay. So in the sinus tach with aberrancy, it mentions that this is going to be a wide complex, so greater than 120 milliseconds. It's going to be tachycardic, greater than 100 beats per minute, as with all these. You're going to see bundle branch block with the sinus tach. So these are going to be bundle branch blocks characterized by positive P waves in 1, 2, and 3. And then you're going to have the consistent sinus rhythm, so a P wave before every QRS complex. And then those will be like the right bundle branch and left bundle branch blocks. In AFib, you're going to have an aberrant rhythm, so RVR, and this is also going to have a bundle branch block with it. So it's going to be a fixed bundle branch block, like your left bundle branch block, your right bundle branch block, or it's going to be a rate-specific bundle branch block. So there'll be some underlying pathology in the heart, where the heart speeds up and the refractory time in one of the bundles isn't keeping up. So you'll get a block. So this will elongate the QRS. But in this, it'll be AFib underlying, so you won't have any discernible P waves. You'll have the wide complex, but most notably will be the irregular rhythm. So that'll be the most defiant for the AFib. AV nodal reentrant tachycardia. So this is also known as paroxysmal supraventricular tachycardia. This is going to be a rapid rate, again, the wide QRS. You can have normal P wave, but you're also going to have retrograde P waves because of the reentrant through the ventricular stuff and through the node. So that's present in about 70% of cases, it says. With that. The next it goes into, from the SVT side, it talks about the pre-excitation symptoms. So here, the wide complex, you can have Wolf Parkinson White, can also be encountered with AFib. So this, again, you'll notice an irregular rhythm with the QRS. And you'll also get some beat-to-beat variation there because you have essentially electrical excitation going through the accessory pathway and through the node. So you'll get fusion beats and capture beats for this. So this, we'll go on to talk about later in the paper that defining things for VTAC is atrioventricular dissociation. So this is one of those things that shows that there's atrioventricular
Rhythm genetic dissociation. One is certain pop and one is
VTAC. So the next is the Wolf Parkinson White with the antigenomic ADRT. So this is where it comes down through the accessory pathway and goes retrograde through the AV, the ventricular septum up into the atrium. So you're going to have a regular rhythm with this with the right QRS. So it's Will Parkinson Light, so you'll still see the pre-excitation or the deltoid slurring in the initial phase of the QRS complex. And then it goes in to talk about the VTAC rhythm. So the monophasic VTAC, and then the polymorphic VTAC, and this, torsades being kind of a subgroup of the polymorphic VTAC itself.
So endodromic is the accessory pathway, and then around the orthodromic is the opposite.
The opposite, and you get the narrow QRS with the orthodrome, because it's all coming through the AV system and going back retrograde. So everything coming into the ventricle is coming through his system. So then it goes on to discuss that there's, previously there was, the Wellens classical criteria, the Brugada criteria, and the Varecki criteria. I don't know how to pronounce that one. So these all look at the QRS complexes in different ways to try to negotiate. Is this coming from a supraventricular tachycardia with aberrancy, or is this specific to a disturbance within the ventricular system itself, leading to VTAC as the underlying diagnosis? And then it also talks about a new system brought up by Becker that suggests these 3 clinical criteria with an underlying diagnosis of like heart failure, previous MI, or angina with AV dissociation. So any one of 3 of those being a positive for ventricular tachycardia. There was a recent review done showing how this kind of new age thought process of differentiating the two compared to the Brugada algorithm or the Wellens classical criteria individually. It showed that there was no performance advantage using this new age system. So they're all kind of similar in telling you apart. So it talks about in the comments that it's very hard to tell, especially in an emergent situation. The patient has a lot of other comorbidities going on. There's a probable underlying cause to something initiating this heartbeat, and it can be hard at first to look at the EKG and differentiate: is this VTAC or is this an SVT with an aberrant rhythm? So it inevitably leads down to how should I err on the side of caution? So it talks about in favor of erring on the side of caution in favor of VTAC as your diagnosis. So to treat as VTAC and not erring on the side as this kid, I'd rather call this SVT with an aberrant rhythm when you're really unsure and you can't meet any of this criteria here. I had to, so reading this paper, I had to do a lot of extra reading and looking at EKGs to go over exactly what they were looking for in each lead.
I explained it to, again, why irregular. And the physiology behind it is you work on people with WCW syndrome. A certain percentage of people with WCW can go into and WCW means obviously you almost have the pathway. So if you go into AFib, what some people may do is they may try to slow it down by blocking the AV. And if you slow stuff down by blocking it, sometimes AFib we misinterpret it as other things. Sometimes it's necessarily fifth letter and one or so if you block the AV node somebody with underlying WCW AFib, and you don't recognize it as wide and irregular, what happens is you block the AV node and then you can speed conduction down the bypass track. And that AFib now turns into VFib. And normally VFib you would shock, but these people you shock and you can't convert them with just a quick defibrillation, even if it's right in front of you, because you still block the AV node and you still have all those impulses that, where AFib is going like 400 or 500 times a minute, and now it's all going down the accessory pathway. So what drugs are the worst drugs for blocking the AV node while speeding conduction down the bypass tracks? And some of the drugs are not things we carry pre-hospitally, like DIG is a classic example, blocks the AV node and speeds conduction down the bypass track. The other classic example that does this is verapamil, but we don't give verapamil that much anymore. So can all calcium channel blockers do this? And the answer is yeah, all calcium channel blockers can block the AV node and speed conduction down bypass track. So classically what we do in pre-hospital or in the emergency department is we give IV cardizem, right? Cardizem again blocks the AV node and speeds conduction down the bypass track. That's why when you see AFib and you want to treat it, your first question should be, is this a wide complex AFib? And if it is, you should stop and not necessarily give Well, you shouldn't give diltiazem. Now, is it safe to give beta blockers? Well, beta blockers certainly block the AV node, but they don't speed conduction down the bypass tracks. But what's really safe to give is, so how do you treat these people? Well, one is if they're unstable, you can shock anybody. Any tachydysrhythmia that's unstable, and to me, unstable doesn't necessarily mean you're having chest pain. It means you're truly hypotensive, and truly altered. So if your blood pressure is borderline and you're maintaining okay, I pick a poison. But if your blood pressure is bad and you're altered, I start to think about cardioverting you pretty quickly. So if you're unstable, you get shocked. If you're perfectly stable, you can just sit on the people and just watch them for a little while and just try to figure out, and that maybe takes you 5 or 10 minutes, 15 minutes to try and figure out what the underlying rhythm is, if it's a Y complex or regular AFib. And what if they're in between? And if they're in between, you can pick a poison, and the best poison literature to pick is procainamide, right? So procainamide is making a big comeback. It's gotten several papers recently about being a good agent, especially for wide irregular rhythms. I generally give my procainamide 750 to a gram over 20, 30 minutes, sometimes even 15 to 20 minutes. I don't know how you guys give it.
17 mg per kg per
Yeah.
dose.
How ridiculous is that? That's a good ACLS question. The max dose is 17 milligrams per kilogram. Something else totally made up in medicine. So I give procainamide, and the risk of procainamide is hypertension. It can prolong your QT interval too. It can widen your QRS, but that's okay because it's a really safe drug in this instance. So a wide irregular rhythm, always be very careful about just rushing toward diltiazem, because those are the people who could have underlying WPW, and you might see this on a resting EKG, which you may not have because the patient just shows up in rapid AFib. You may not see that delta wave, and then again, you don't want to speed conduction down the bypass tract, and that's kind of how I think about this, just as simple as possible.
I've had some success using the Ottawa aggressive or atrial fib protocol that we've read. Dr. Hemphy turned me on to that, and that's what you're saying, a gram of procainamide over an hour, and 2 out of 3 over the last 6 months have converted well.
Right. So we're a big lover of procainamide. The problem is procainamide is another drug that's on back order. So we're having a lot of difficulty putting it on the paramedic units. If it wasn't on back order and was available, I'd put it on every single ambulance in the world, ALS ambulance. But we're having difficulty getting it. So if you're the procainamide manufacturer out there, please help us out. You have a great drug for this incident, for this situation, as well as several other situations we're not talking about. And procainamide was the old drug that induced, anybody know what chronic procainamide used to induce? Lupus. Right, so procainamide induced lupus. And procainamide's a 1A antiarrhythmic, right? What are the other 2 1A antiarrhythmics? Quinidine and
dose pure. I don't know.
Yes, Norpace, which we give for people who have neurocardiac syncope, right? Because it's a big anticholinergic antiarrhythmic. And of course, we're talking about the antiarrhythmic classification, not the ACLS recommendation classification, right? So it's a 1A antiarrhythmic. Anything else with this article?
I think that the key point is when you're unsure with wide complex tachydysrhythmias, you just treat it like VTAC, right? Just be safe. Give it procainamide. Give it. You're not going to give VTAC or like an AV blocking medication. It just doesn't make sense. So unsure, treat it like VTAC. Always be safe. I think they mentioned in there. I can't remember if it's Alamatu who talks about it, but in people with WPW, that accessory pathway, and they go into AFib spontaneously, like you said, a certain percentage, I think it's like 15 or 20% will develop AFib.
Yeah.
The atria is fibrillating at about 600 times a minute.
Yeah.
So as soon as you knock out that, the normal
That's what
pathway,
we say. Atria goes 40 something times a minute. You block.
It's insane.
So you block the AV node and you speed, but the worst part is you speed conduction on the bypass tract.
Right. And then all of a sudden it's
right.
Done.
And that's the problem. You can be standing right next to them, shock them immediately, and it's just probably not going to work because that drug, particularly if you're using something like verapamil, which is a little longer acting than other drugs, it's just not going to work because you'll still be blocking the AV node. And this has happened to a few people I know in the emergency department, other places, where they gave a drug and like diltiazem, like verapamil, and they went to VF and it was wide and it was irregular, and they couldn't get the guy back, even to young people too. Anything else? Anything else with anybody for this? All right, that was good.
It's a good review, right? Yes.
So
It was good to read, that's for sure.
Now you understand it a little better. At least I did. That's right.
Yeah, it was good because it had me reading a bunch of other stuff on top.
Yeah,
So
yeah, like this to get a good handle on this, you gotta read all these articles 3-4 times. I recommend doing it on a Friday or Saturday night, and staying home and reading these articles over and over. Well, what about here? Let's do the end-tidal
Sleep
CO2
sound.
and the VF article. Did you guys like that?
Which one do you want to do?
Either. I can do it. That's fine.
Okay.
The nasal cannula one or the defibrillation one?
The defibrillation one.
Yeah, I thought these were both interesting articles. Yeah. Alright, which one do you want to do first? Wait, which one do you want me to do?
Do you want to do
defib-
end title with
I know.
defib, the
Yeah.
defibrillation study?
End title.
So
Wait,
resuscitation,
oh,
so
sure.
resuscitation paper?
Success.
Yeah. Okay. So this article is basically looking at using end title to possibly indicate when we should give shocks to people who are in VF or pulseless VT. So what they did was, I think this was, if I remember correctly, retrospective review of monitors, looking at the monitor, I guess the printouts, and looking at the end tidal CO2 value of the minute preceding to the shock, and then looking to see basically if the shock was effective or not. So they looked at, they basically found there were three different values of the end tidal CO2 1 minute before, below 20, between 20 and 31, and above 31. So, so what they did, so basically what happened was they had about 1,500 patients that were enrolled in the study, and 931 of them, resuscitation was attempted. 167 had VF or VT cardiac arrest, but 62 of those patients had the end tidal CO2 values available, and in total they got 207 shocks. So they looked at basically these 62 patients, and what they defined as, so they looked at the shocks given, and then they wanted to see if there was an organized rhythm within 60 seconds after that shock was delivered. So they defined an organized rhythm as at least two QRS complexes separated by no more than 5 seconds. So I think that's something that's important to kind of think about as well, because I don't know if 2 QRS complexes on its own and then there's no rhythm after that, it necessarily is enough to say that the person had a sustained ROSC, but that's something we can kind of talk about afterwards. So what they found was, it was interesting that in the cases of, so the higher the value of the end tidal was, the more likelihood that basically the shock was going to be effective. They found that there was basically 0% chance of a shock being effective when the end tidal was below 7, and I think there was 100% that the shock was effective above 45. So in that first third of the patients with the end tidal below 20%, only 50% were effective, whereas if it was above the third third, which was above the end tidal above 31, about 80% of the shocks were effective. So I thought this was something that was kind of interesting overall, and possibly determining, well, the best time to give the shock. So they were talking about that maybe if you should wait till you're giving good enough CPR to give the shock. Maybe that will help change them into a better rhythm. On the other hand, though, maybe those people have better end tidals because they haven't been down for as long, or they're better candidates, so to get ROS. So maybe inherently in and of itself. So I think there's some questions that are going on with this, and I don't know what the exact answer is, or if I would necessarily delay a shock that could be given. Although I think this goes also to talking about hands-on defibrillation that we've talked about previously, so that maybe if we are giving good CPR and we have a good end tidal, we should continue with the CPR and give the shock while we're still doing CPR so that the end tidal doesn't drop. And that, to me, is, I think, maybe the direction where this could be good to go to, because it's stopping the CPR, the end tidal may drop at that point. So if we're already showing, we don't know exactly why the end tidal is low in these patients,
but maybe if we can keep it high while we're doing the CPR and give the shocks at the same time, maybe they'll convert better. So I think it's an interesting study and stuff to kind of think about and to keep in mind for now. And I guess, and then putting on the entitle on the people, even if they're not intubated, we can have those nasal prongs that we can use to get the entitle as well. I don't know if everyone carries that, but it's something I guess to consider when you're before intubation as well on your patients.
I mean, I thought this study was really cool. It's conceptually, I guess it makes sense. Well, there are limitations like you suggested, but maybe, when do we shock people who are running the codes? And the answer is it's somewhat random. And if you're in VF, whether I shock you at this minute or the next minute, it's just whenever the team leader calls it. Or whenever the nurse shocks you. But maybe conceptually to shock people when end-tidal CO2 is best, maybe even if it's because of CPR. The minute somebody gets that CPR, the more effective CPR, and that's when you start shocking, if they have better rates of frost, maybe I would start to change what I do. What's the downside?
Right. So let's say you hook someone up to a monitor and the end-tidal, and they're in VF right off the bat, but their end-tidal is only 20, let's say, or 15. Would you start CPR and then shock them, or would you just shock them?
Right,
and then...
so that was those initial articles a couple of years ago which talked about waiting. But as excited as we were, the meta-analysis of all those studies said that concept was totally wrong, right? So waiting in an unwitnessed cardiac arrest, we had thought that was the right thing to do, and then the literature taught us that we were wrong. It wasn't the right thing to do. So to answer your question, I wouldn't wait. If I hooked somebody up in their VF, I would shock. But after that initial shock, so I would never delay a shock waiting for an end-tidal CO2, but the minute I starting to go up would be a cue for me to maybe call for defibrillation a little bit quicker. That's what I think what I'm left with.
Yeah.
But it does kind of, on the other hand, to play devil's advocate, if I keep shocking because of what's on the monitor, I am not doing compressions, right? Because most people aren't doing hands-on defibrillation, right? So I'm not doing compressions, and maybe that is why more people don't survive VFib arrest. So I'm willing to say maybe the answer is to not shock early and to shock at more appropriate times, because right now we don't know when those appropriate times are. This may be the first article that tries to tell me when are those appropriate times. What do you guys think? We have a famous doctor in the back who doesn't want to be identified. Ron, what do you think?
I would think that if the end tidal is a good marker for effective CPR, and you've got probably a better pH balance within the body, and you're effectively getting good perfusion, then defibrillating at that point would probably be more effective than trying to defibrillate when the body's acidotic and the perfusion's not as well. So kind of like Josh's idea as far as, engaging your CPR defibrillation by when that end tidal is improving, and also probably, of course, right after right after the defibrillation, get back on the chest and just make sure that we continue with that CPR, and then not do the pulse check, which is something that we've had a little problems with in the past. People go back to the old ways.
Right. So instead of saying it's been X number of minutes to shock this persistent VF, if it's been 30 seconds, all of a sudden the end-tidal CO2 doubles, just shock, right?
I would think if you're up in that range, take advantage of it.
Right, but then Josh's question is tough to answer. What if you see it's an unwitnessed arrest, it's VF, and normally we all get taught now to shock right away. Maybe those are the people you wait and don't shock right away. I don't think that's true, but I'm open to the idea that it might be.
I would think that when you walk into a room and you have somebody that's in this condition, they're unconscious, they're unresponsive, and you determine that they have VFib, or they're pulseless or happening, then you should just begin CPR eventually. It's going to take them a while before, even if you walk in with the monitor or you walk in with the defibrillator, then automatically somebody should be on the chest and not opening up the shirt. It's going to take you a while to get the pads open and whatnot. I think that was the whole concept, was to early CPR, early effective CPR, to really prime those patients up so that defibrillation can be more effective. And I think this study kind of corroborates that.
Although in Mike's case, you had a high end-tidal CO2 and nothing
Yeah.
on the cardiac monitor.
You should have kept going.
Yeah.
And what? And
Thanks.
did you shock at all?
We shocked once.
One shock, yeah.
I mean,
It was weird. He went from that narrow complex bradycardic PEA into VFib. We shocked him. Then it was like asystole for a while, and then back into that bradycardic PEA. It's
right.
weird.
For all those people who say you can't shock in PEA, I go, geez, we don't know what we're doing in cardiac arrest. Like,
Are you gonna harm them by doing
What's
that?
the
I'm
law?
always tempted to just start like pacing and just see if the heart will pick up and just go and start.
Right. Except the problem is our transcutaneous pacing
Yeah.
methods are pre-hospital are so terrible.
That's why we just drop, transvenous spacers in the field now, right?
Right. Yeah.
Is that
Tomorrow.
correct?
Tomorrow.
You can get in the shipment.
Any other thoughts about the paper?
I just think this thing fits into our mantra. I mean, if you have somebody in cardiac arrest with pulses, start CPR immediately, defibrillate as soon as possible. When you see a rise in end-tidal CO2, it's the best marker of ROSC. If you don't have a rise in CO2, you continue doing your regular stuff. If you're in VFib, shock with hands-on defibrillation. I mean, if the end-tidal CO2 is a marker of our perfusion, you're more likely to convert. I mean, it's more of a prognostic.
Kind of makes sense.
Yeah.
Yeah.
I think it just fits into our regular.
I think it's interesting, but I don't think it's going to change my management. If I see a shockable rhythm, I'm going to shock them. I don't care what the entitle is. I don't know.
For the shock rhythm is fine.
Well, for the first shock you would shock, but then
Yeah.
subsequent
Yeah.
shocks.
If you had a persistent VF and
After
your
doing double
end-tidal is
sequence
20,
and then trying my ESMOL and and everything like that.
if you have a persistent VF and your end-tidal CO2 is 20, all of a sudden it bumps up to 30.
Yeah.
Maybe now you say, okay, let's shock really quick.
Yeah.
Right, and whereas you might have waited like 2 or 3 minutes to give it more drugs, which don't work anyway.
Yeah.
To stay within the protocol. But also
Yeah, I
you
guess.
can ultrasound the heart and see what's going on with the heart. Also see if your CPR is effective. You can move your
I mean,
placement.
it does make sense. The ultrasound just looks at the heart. The end-tidal CO2 tells you a little bit about
Gives you more
the
information.
perfusion. So
And it's more accessible right now, especially because
The
ultrasounds are so
alternative-
very
The alternative is
expensive.
an A-line. In the hospital,
Right.
femoral A-line might be helpful, but in a pre-hospital setting or in
Right.
Early
but for everybody who's doing femoral A-lines literature and looking at it to say how you should compress and diastolic pressures during femoral A-line, you still don't have good literature to say this is the right thing to do. I mean, it seems interesting to me, but you just don't have good science that say this is like changing outcomes in people.
Does anybody out there use femoral A lines in cardiac arrest?
Right, because this is talked about. This is talked about by a lot of people, and a lot of people are, well, a lot. Some people are doing it in teaching hospitals, maybe some community hospitals too, and they're keeping the diastolic pressure at a certain amount. But yeah, if only more people walked out of the hospital alive, it would be great.
Right.
The problem is doing this in a teaching institution is easy. Doing this in a community hospital where there's one physician at a cardiac arrest, how do you put a femoral A-line to everybody in the community hospital and run the code and still see all the other patients in the ER?
Yeah.
It's that especially with people who have very low chance of survival, And the question is, well, maybe you pick your patients better. That's probably what some people are saying. You pick your patients better. Again, I agree, but you have to think, how easy it is for the average community ER physician to do.
Right. Yeah, and that's we talked about this before. When you're at a community hospital and you're running a code and they say, oh doctor, there's a stroke coming in. It's like, tell the other doctor to get it. He can't. He has another cardiac arrest. It's kind of like how much am I going to be able to do here? I guess in a teaching hospital, it would be great if we could throw A-lines in and kind of make that standard of care. But does it happen?
But your end-tidal CO2 is a non-invasive marker.
Right.
And we put A-lines in all cardiac arrest, but
Yeah.
no, I mean it's another open needle, and
Right.
we know that we don't need to put central lines in any more cardiac arrest. And,
Right.
just tell me changes outcome. And most of
Yeah.
our cardiac arrest are older patients who are not going to survive, especially when we don't get to them right away and we don't have a shockable rhythm right away. Okay, how about the apneic oxygenation review?
We'll talk about that. I just have to say we have members of the veterinary community watching as well. So
All right.
there are a lot of shout out to Lisa Murphy. She's a well-known critical care specialist in the veterinary world now.
Where is she at? What state?
She's out of LA now. She's in Cali, but I think she's actually moving back to the area to work.
All right,
here
thanks for
in
joining
New
us.
Jersey or Pennsylvania.
So this apneic oxygenation was review in Annals of Emergency Medicine, and it was like a meta-analysis and review of all the literature.
Yeah.
So I always tell people, if you're not doing apneic oxygenation in people, you are only I mean, Levitan's article about no DSAT was, which had a lot to do with cannulas, but it was also on apneic oxygenation, was, I believe, from 2010. And then this article, I think, looked at over 1,300 papers. So you're only 7 years and 1,300 papers behind the time.
Right.
So please catch up.
Right now. So this was just yet another study kind of reinforcing the importance of apneic oxygenation. I'll put the microphone close to me just like I did for everybody else so it's nice and fair. So for those of you watching at home, effectiveness of apneic oxygenation during intubation, a systematic review and meta-analysis. So we've seen study after study. We've looked at previous meta-analysis, I believe, as well for apneic oxygenation, and it seemingly shows the same thing. So if you've never done this before, basically the theory is during laryngoscopy, you're intubating somebody, you keep high flow nasal cannula on, which is keeping the airway, the dead space, full with 100% oxygen, and you get some passive oxygen exchange as well. That kind of drives forward, and the chance of hypoxia during intubation is significantly less. And as we will see, this is starting to affect outcomes as well. Not all patient-oriented outcomes, but I mean markers of a successful intubation, things like that. So it's, basically we should all be doing it. That's, I think, the take home, because we're really not harming anybody. So let's focus on the meta-analysis part. Basically, this is a meta-analysis. I believe it's 8 emergency departments and ICUs. They looked at like 1,800 patients over a period of time, and ultimately their outcomes, they were looking at first pass success. That's a major outcome we're looking for in intubation frequently in the literature.
Everybody uses that, although we as an academic group don't agree with that, right?
Right.
And many authors write papers that the first pass success is something that is important in a paper, yet it's not the be all end all. It's
Right. It's still not a patient-oriented outcome. It's
right.
not.
It's the journey of getting the tube through the cords. It's not whether you get it on the first shot, because if you get on the first shot, yet you cause hypertension or bradycardia, then that was not a successful intubation. So it takes you 2 or 3 attempts, and you don't get hypotension or bradycardia. That is a successful intubation.
Right.
Sorry, keep going.
Oh, no problem. So, as we said, it's not a patient-oriented outcome, but it is, something that's frequently reported. They also looked at incidences of hypoxemia, so less than 93%, severe hypoxemia, less than 80%, life-threatening hypoxemia, I like how they keep going, less than 70% SpO2 during the procedure. And then they looked at a few patient-oriented outcomes as well, so like length of stay in the ICU and mortality in the ICU. So those are important things. I think, if anything, you care more about those than anything, because you're wondering if the patient actually walked out of the ICU, or did they die in the ICU after all of our interventions. So if you look at Table 1, that kind of highlights most of the studies that they are referencing, diverse between ICU and ED. Some of them were randomized controlled trials. Those were included in the meta-analysis. And they also reported observational studies where, that was part of more of the systematic review side of the paper. The population, it's, you always have to ask yourself is this the same population that I'm, dealing with in my emergency room? These are patients. It varies. I think half of the papers that they reported were critically ill patients who were getting intubated in the ICU. The other half were, or in the ER. The other half were ICU patients who maybe had a little bit more time for pre-oxygenation, a little more time for optimization. It's not like your crash airway, so you have to kind of take that into account. Overall, though, these are all pretty sick patients, and so let's just start looking at outcomes. So they were basically looking at all patients who got apneic oxygenation during intubation and comparing it to patients who got standard care. So no nasal cannula on high flow during the intubation. If you start looking at figure 2, as in all meta-analyses, you're going to start seeing a bunch of forest plots and whether or not they favor a certain intervention. So figure 2, A, B, C, and D, A is going to be looking more at your lowest oxygen saturation. B's on figure 2 is looking at your first pass success. C, hypoxemia. D, severe hypoxemia. And then E, life-threatening hypoxemia. So in general, if you just kind of look down the line of those forest charts, we are favoring apneic oxygenation. And if you see at the bottom of each forest chart, there's a diamond, a sideways black diamond. And if we want that to be on the side that favors apneic oxygenation without crossing 0. So the confidence interval is going to be significant. So so for A, the let's see, lowest oxygen saturation, it is significantly, you have less of a lower oxygen saturation in people who are getting apneic oxygenation. Totally makes sense to me. First pass success as well. B, we're on that favors apneic oxygenation side of the line. So out of all the studies they look at, same thing. C, exactly same thing. So people who had hypoxemia less than 93%, we're on, the diamond is on favors apneic oxygenation side of the forest chart. So good. So once we get into D and E, we're looking at severe hypoxemia and life-threatening hypoxemia. While the trend is favoring apneic oxygenation, the diamond didn't actually cross the midline. So so it's not statistically significant. The next chart, figure 3, more forest plots of the meta-analysis, and those are really looking at post-procedural outcomes, which are probably more important to all of us. A would be the duration of mechanical ventilation. If you look at that, the overall total is, it's favoring apneic oxygenation. It's just barely there at the line, so I think it does technically cross 0. I don't know if they reported this one as statistically significant. But I would call it yes. B is duration of mechanical ventilation, or no, sorry, ICU length of stay, and we can see that we did favor apneic oxygenation with length of stay as well. So that's decreased length of stay. I think that in itself, even if we're looking at mortality overall, if that's not clinically different, I think ICU length of stay is something that's important to all of us. We're decreasing resources, we're decreasing time of a patient staying in the hospital. And ultimately, the longer in the ICU, the more likely you are to have crap happen to you. Vent-associated pneumonias, bad outcomes associated with being on a ventilator for so long. So if we can reduce the ICU length of stay as well. Yeah, exactly. So, so those, I mean, that's pretty much a summary of the meta-analysis side of things. You could argue that most of the studies they looked at were not, in fact, reporting patient-oriented outcomes. So they had to filter out, if you look at the chart back that showed the whole study protocol, figure 1, they had to filter through a lot of a lot of studies. They looked in gray literature, so abstracts of unpublished literature. They started with like 13,000 papers, and they filtered it down to 8 ultimately. So I pity whoever had to do that, because that's not really a job that you want to have. But their limitation, I guess you could argue, is they really had strict inclusion criteria, which we want to see, but they really decreased their N in the end. So that would be considered a limitation. But meta-analysis, I think overall, that's the best type of study you want to see, right? That's a lot of data. They can apply their criteria and their limitations to a bunch of data that and basically put it all together. And we did see some significant improvements in patient-oriented outcomes. So, I think apneic oxygenation, if you're not doing it, I mean, why not? It's cheap, it's easy. You put a nasal cannula on every patient you're going to intubate. Even if you're not intubating, you're going to pre-oxygenate them. Maybe you're doing a delayed sequence to see if you can turn them around to not intubate them. Just have the nasal cannula on underneath your CPAP. I think you just have it on ready to go. It's cheap, it's easy,
Everyone has it.
everyone has a nasal cannula.
I mean, what's the downside?
Right. Yeah.
Yeah. So,
I mean, the fellows trial that came out like 3-4 years ago.
Yeah.
I think we talked about that.
mention
That they didn't really have any different
I think they mentioned this study, but their outcomes were really not significantly improved. One of the arguments was, well, you're in an ICU setting. A lot of these patients are already like ARDS. They're already on BiPAP. They're already being pre-oxygenated, so they're not really coming in presenting in a crash state, right? It was a nicely done pragmatic study, but it's not really the patients that we're looking at. Those patients, majority of them were on BiPAP for weeks before they considered re-intubating them in the ICU, right? So.
That was a different study, but
Yeah.
the big mistake we do is we don't apply like a Bayesian thinking kind of to all the literature. We take all the literature and we come up with a conclusion. Instead, we will publish 10 papers that say drug A is good, one that says it's bad, so we come to the conclusion that drug A is bad.
Mhm.
Right? When you have to weigh and measure all the studies. So meta-analysis is certainly can be associated with a lot of different statistical errors. We know that it's a nice way to look at all the literature. So I wouldn't say the fellows trial means we should not do apneic oxygenation, right? It means we should just take it at face value, weigh it with all the other literature, and look at what the downside and risk is of doing apneic oxygenation. And I still believe in the majority of cases, this is the right thing to do for patients.
Mhm.
I don't need any more studies, right, to
Yeah.
tell me to start doing this. What do you guys think? I think about all the patients for years that I intubated with no high flow nasal cannula and didn't put a PEEP valve on a BVM. And I was doing the wrong thing because somebody taught me
Yeah.
to rush to intubate everybody,
Yeah.
and they taught me the wrong thing.
I was lucky enough to be trained at an institution that it keeps, that's part of the training. It's in our airway checklist. Every time you go through your airway checklist where I was trained, you have your oxygen, your nasal cannula on, you have your non-rebreather on, 15 plus or blowing off the wall, as they always say, or your CPAP is in place, right? And you set up your bag, you have your PEEP valve on, ready to go. So.
Right. Why
This is
people
part of
today
your
still
checklist.
squeeze the bag of death with no PEEP valve on makes no sense to me. At least, I mean, we publish, we've looked at national standards lately, and it's nice that more national standards are including PEEP valve, but now it'll take people a few years to read the new standards, right? Whereas, I mean, when did we start putting PEEP valves on BVMs? Like 5 years ago?
Yeah.
Or doing high flow nasal cannula like 5 years ago?
At least.
Right? And people say, well, we're not doing that in my emergency department. I go, really? My medics are doing it all day long, every single day.
Yeah.
Right?
Still, they're doing it the wrong way. Still today, still happens.
Right. It still happens
Still
all the
see-
time. All throughout,
Hurry up
not
and
just
get
the
the
United
tube in.
States, but the world. But
Hurry up and get
hurry
the
up
tube
and
in.
get the tube
Still-
in. Or the worst sentence is, the sats are falling, beg faster.
Right.
Right?
Terrible.
And that is associated with worse outcome when you do that.
Yeah, and I think now that I work with residents, like we supervise residents, I think one of the mantras that I kind of subconsciously learned or knew through residency that nobody ever verbalized to me was resuscitate before you intubate. And now more than ever, I think that's becoming a prevalent topic. So now when I'm in my community ER out in the middle of nowhere and you're sitting there taking your time to intubate somebody, you get a lot of weird looks. People are looking at you like, what's taking so long? Just get the tube down the throat. I'm like, well, no, the blood pressure is 60/40, the oxygen saturation's for 50%. I'm going to take my time and optimize my outcome first.
Because the chance
it's
to go into
only
cardiac arrest for when that patient is 50%, and if you do all the other stuff,
Right.
it goes to 1 in 5.
So some places that have some respiratory therapists who intubate without the doctor knowing about it, that's kind of scary to me because you don't know what's going on, and you walk. I'm not talking from personal experience, of course, but you walk
So we have
into
to
the room.
correct that
and-
for all the respiratory therapists who will be watching this.
I
Um,
found a lot of the new respiratory techs are coming out. They actually know all this.
A lot of them keep up to date with what's
'Cause
going
that's
on. And
actually their job
if
is
they're
all day.
intubating in the ER or in the hospital where they work, most of them will keep up with this. So it's great.
Yeah,
So-
that people often tell you that people have written a lot of review articles that RSI is not rapid sequence intubation. It's, R could be resuscitation sequence intubation. Resuscitate first. Resuscitate. Right. Don't rush to put the tube in. You have 3 full minutes, unless the patient is really completely not breathing, or their sats below 93ish and their respiratory rate is less than 4.
Crash intubations there.
Yeah. You got 3 minutes to get the blood pressure up to do passive oxygenation and to prepare, and that just yields better outcomes, right?
Mhm.
And again, there's a difference between a patient who maybe goes down in front of you and a patient who is unwitnessed, and we know this, and maybe that's why some of the apneic oxygenation literature wasn't
overwhelmingly supportive because, just like you said, some of these people are well oxygenated to start with. Any other comments? Dustin, you're doing this in the ER every time?
Yes, they're not doing it in all the EDs in the area. Some of our away rotations.
So I wonder if they do this on dogs. Any comments from the veterinary community? Or is-
Just think
My
about it.
wife's
For years, we
gonna
put a
kill me.
laryngoscope in somebody's mouth and said, we know you're sick enough to need a laryngoscope, but you're not sick enough to need oxygen. How crazy is that? What were we thinking about? And like nobody stepped forward.
Is it one guy to say the laryngoscope's a murder tool?
Yeah, it's a murder weapon, right?
Right. It is.
Yeah.
Right. Oh, and a laryngoscope in the wrong hands with RSI.
Yeah.
Right. All right. Was there one more article? Did we miss one?
Yeah, there's the end title, the waveform capnography as an alternative. to
Oh yeah. Did
physician's
you like this one?
Gestalt.
I kind of like this one.
I thought it was a neat study.
Who was the first author? Can we give them
Yeah,
credit?
let me pull it up. So I've got the.
Who was the first author on the Annals paper for outlet oxygenation? We should give them credit. SCOCCIMARRO. We should actually give the person credit who went through all 1,300 articles.
Yeah, I think that's the person who deserves the most credit. Yeah, I can't. Unfortunately, Anthony Scocomimoro.
This is, I think, out of Lincoln. This
Was it at
the
Lincoln?
waveform one was out of
That's a
Lincoln.
waveform capnography one.
Yeah. So not too far away from us. So, if people are not, I can certainly talk about the article, but my voice is a little monotonous. If anybody is.
Anybody else want to do this article? Last one of the day.
I could do this one too.
All right, Josh.
So this one looked at waveform capnography as an alternative to physician gestalt in determining optimal intubating conditions after giving paralytics. So basically what happens is, what has been happening is generally we would go to intubate someone, we give our medications, we give our paralytics, and then we wait a minute, 2 minutes, kind of depending on what medication we give, and then we feel the jaw, or people will do an eye blink test, or different things that people kind of do to say, all right, I think this person is paralyzed, and then attempt to intubate them. So what this study looked at was doing that versus attaching them to end-tidal CO2 and waiting for there to be a flat line on the monitor of the end-tidal CO2, not of the heart rate.
That would be preferable.
To determine when they should be intubated. And the reason for that would be the person stopped breathing, so we're not going to see the waveform of the end-tidal CO2. So at that point, we could reasonably assume that the patient is paralyzed and then go to intubate them. So this was a pilot prospective observational cohort study, and this was for basically all patients who needed to be intubated, except for people in cardiac arrest, traumatic arrest, or when awake intubation was performed. So it was 50 patients in each group, and in the Gestalt group, patients, the paralysis was determined by physician judgment, so that's if they did the blink test or checked for muscle fasciculations or mandible relaxation. And in the waveform capnography group, then, like we discussed, it was waiting for waiting to see the flat line on the capnography monitor. So the medications, the paralytics were used were succinylcholine or rocuronium, and then what they looked at was time to intubation, which was defined as the time from administration of the paralytic agent to confirmation of tube placement by end-tidal CO2, and this was measured by an observer in the emergency room. So what they found was that in the physician Gestalt group, there were more failures to determine the optimal intubating conditions, and the value was 32% versus only 6% in the waveform capnography group, and the time to intubation was longer in the Gestalt group and versus the waveform capnography group as well. So I think this is a interesting study to help us think about the time that when exactly we should go to intubate people. And I know in my own personal experience as well that sometimes you may think a person's paralyzed, and by moving their jaw it feels like it's loose, and then you go in, they may still have a gag reflex. So it may help provide better optimal intubating conditions. Again, I think it's important to look at, if we have these modalities available to us, so hooking them up to it probably shouldn't take much extra time, especially if we're going to be doing apneic oxygenation. We can do that through the same cannula that can measure end-tidal CO2. So we can use that and put that on right off the bat. So this could help us determine, the best time to intubate someone. Again, I don't know if this makes a difference in terms of a patient outcome or not, but if we can better optimize an intubation and allow for less desaturations or trauma to the airway, then it may be worth it. So I think this is something that is, kind of in the line of what we're doing and the other things we're doing in medicine and emergency medicine. So maybe something worth considering doing in the ER or pre-hospital.
Jim, what's your trick if you don't have nasal cannula and tidal?
So you have the endotracheal tube adapter. You can cut that hard plastic 15 millimeter adapter off and just have the tubing. And the tubing can be placed inside a nasal airway or just placed right into the nasal pharynx. And you can get it down to the glottic level. And a lot of times with the nasal cannulas, on a high flow nasal cannula, you get a lot of washout from the high flow rate of the oxygen. You don't get an accurate end-tidal CO2 level. So inside BiPAP masks or inside CPAP masks with a high inspiratory flow, you get a washout of the end-tidal CO2 and you really get a great measurement.
People ask if that's accurate. I mean, I don't know, but
It's delusional.
I bet it probably is.
So if you can get the catheter at the level of the glottis, you get a lot you get a more accurate reading in my experience.
So with the commercial device, though, if you turn up the oxygen too high, it'll also wash out.
I think it's limited to 5 liters.
Yeah, so you'll see, like, if you turn it up past whatever the actual limit is, you'll see that you lose the waveform. So usually what I do is I turn it up. I treat the patient, and then when I actually need my waveform, I just turn down the oxygen.
Any other thoughts?
I kept thinking of my time in the OR when we were learning how to intubate. That's really what anesthesiologists do. They're sitting there staring at their end tidal. Obviously, sometimes they put that little shocker on. They checked for muscle paralysis, and but really, when you're learning,
they do train a force.
Yeah.
When you're at the head of the bed after you push that paralytic, that's 60 to 90 seconds. You lose all span of time. It's the longest 60 or 90
Right.
seconds.
Yeah.
It's something that you do in
I
the
don't think
OR
anybody
in
can accurately
perfect
measure.
airways, right? And we don't do that. I don't think perfectly in the emergency department. We don't wait long enough.
If you rush to intubate, there's no sense even giving.
Well, Mike will tell you. Mike, what will you say? If you dose rock perfectly at the onset of action, it's the same as sucks.
Sure.
Yeah,
Well,
1.5 mg per kg. It's exactly the same as sex.
Right. People always say that, and it's just so wrong. I know that rock takes longer to start working than sucks.
And some
So
people
if
even push it
when
before they're
people tell you this,
sedative.
you at home, when people tell you this, and they will for the rest of your life, those people are completely wrong. When you dose rock perfectly, which is what dose, Mike?
1.5 mg per kg.
1.5 mg per kg is the same onset of action as succinylcholine. choline.
So you push it fast and use a lot of it.
Well, that's the argument for, what do you push first, the
Just push it
induction
all.
agent or the paralytic agent? Well, the right answer, of course, for years has been you push the induction agent, because nobody should have, and it's simple to remember, nobody should be paralyzed without being sedated, right? However, some people are writing papers now to say it probably doesn't matter that much because if the agent, the induction agent may just work much quicker if you push them all together, right, than the paralytic. I mean, for me, I still give the induction agent first because I want to guarantee. What do you guys do?
Push it all in one shot. Fentanyl, ketamine, rock. Push it all in induction.
Right.
I find that the biggest problem, and I guess why they did this article really, is that people just intubate too fast.
That's it.
You
Yeah.
push the med,
You
and then
get-
suddenly it's just
You
like
get
they're
scared.
trying to
Yeah,
leave.
just go.
You gotta
And-
wait. It's a long
I think
60
it's a
to
lot of
90
emergency
seconds
medicine.
here.
We get into this moment when we see a patient come in through the door, we get excited, we start moving, and it's very hard for us to kind of stand back. And I think like this with everything else, it's important to kind of take the time to think about things and before we act, and there's value in also waiting and seeing what happens.
And I think that's the biggest lesson, or most difficult lesson I've had to learn over the last 20 years of my career, is that therapeutic pause. Just wait a second, let everything work, see what happens.
It's the same with
take
the
a
pulse
breath.
ox after you're bagging, right? When it doesn't come up right away. It's called the pulse ox land. And you just stand there, you go, I know it says 70 on the monitor. It's a good waveform. The patient's not having any, let me look for objective evidence. The patient's having no new ventricular ectopy. They're not getting more bradycardic, and I'm doing everything right. So let's just wait, and be it, a couple of seconds, 8 breaths, whatever, 3 breaths, whatever you think. Just wait a second.
I wonder how many ET tubes get pulled because of that lag.
Yes, right.
I know I saw it go in the cords. And then your attending says, "Take it out." It's like-
Well, what's the best way to know the tube is in the airway? And the answer is you saw the tip go through the cords. It's not breath sounds or any of these devices. That's all silliness. It's seeing, right? So when somebody says, when somebody intubates, I say, "Did you see it go through the cords?" And it's either yes or no.
Cords is waveform capton.
Yeah. But sometimes, waveform gonography is good, but color change is by no means the be all and end all. I still don't understand why people look for color change when you have an end-tidal CO2 on the patient.
Yeah.
Right.
It's just
I know you're focused on the
There's
color
a box
change.
to click off
Right.
there.
Yeah.
But we have a continuous end-tidal CO2 with a number.
Yeah.
Right? I know
Yeah,
where it is.
Beautiful
right?
waveform. I mean.
Or we're
It's
all
the same
just
color on the waveform.
Yeah.
right. So.
Everybody feels better once they see that good as gold.
Right. Especially if it was difficult to airway. If it's difficult to airway and you don't have a good pulse ox, just wait a couple of ventilations. Right? Don't just pull it out. Because you're gonna feel foolish if you can't get it back in and you knew you were through the cords in the first place. That's happened
And
to me.
you just cause trauma, swelling.
Right.
Yeah. Every time you go in, you're decreasing your chance of successfully intubating again.
Right. And hopefully, if you're a patient in cardiac arrest, you're doing continuous compressions because the other guy doing CPR is more focused on the airway.
That's one thing, that one cardiac arrest we talked about, in the guy who stepped out of his car and then collapsed. I think when I showed up, they were seemingly having some difficulty with the airway. So ultimately, as soon as I got back in there, they were like, "Do you want to look?" And I was just like, "No." I think they were shocked. I said, "Just drop a king tube." I think because just don't want to waste your time. Every time you look, you're decreasing survivability. I think.
Right. King tube. If a paramedic brings a patient to the ER and all they have is a king tube, the right thing to do is leave the freaking king tube. Don't try and intubate. That has nothing to do with survival. Focus on circulation.
Yeah.
Every single time. If you can't get endotracheal tube right away, just drop a king tube. It's very simple. That intubation is not associated with better survival in any study ever, and several studies say it's associated with worse outcome.
I'd be more prone to just use the supraglottic airways for all codes.
Right.
Because
Listen.
the pause
Why
necessary.
waste
Well,
time?
some institutions are doing that.
Yeah.
They don't let you
What I've
intubate.
seen, and that's
You push
something
through the
for-
clot.
Well, this is the rock data, right? 6 minutes, you're not allowed to touch the airway. That's
Right.
how most of ALS works in the country.
We did that big review.
But listen, if you're in a teaching institution let me start at the beginning. Once you get ROSC, I think you should intubate, right?
Right.
Everybody agrees. Once you get ROSC, you pull out the tube and you intubate, whether it's VL or DL, doesn't matter.
Fortunately, the ET tube is still the definitive airway.
Right, and then, if you have if you have enough expertise that you're good in airway and people want to try once, I think it's totally okay. But if that once becomes too difficult, and to me, once includes a laryngoscope going past the central incisors. For all people who argue that it's stiff in the pre-hospital setting, well, this is the standard that's been established in the entire world in the anesthesia community, that when you put your laryngoscope past the central incisors, that counts as an attempt. And we know that worse outcomes associated with not doing good compression, so intubation. So I don't think we can change the definition for pre-hospital providers. Because if you're looking and you don't have high flow nasal cannula, then that is still associated with worse outcome. All right, anything else with this study? Any other studies? Time is it? 2:45. All right, we're good. So next week we are back down at Monarch, right?
Yes.
1 p.m. next Wednesday. I'll send the articles out probably Sunday. If you want, look at our fellowship website, www.emsfellowship.com. To let your friends know about our Facebook live stream. We'll have more articles. If there's some questions you want answered, ask them, and then we'll look at stats for today. Any other thing I'm missing? Okay. Thanks for joining us.